yeah, so I just like gather these terms and concept, and let's say it would be a very, very, very quick overview of the things that you might be able to think about in terms of like popular terms or popular concept that can be used in health economics. And yes, it's adapted from a course, Introduction to Health Economics, that I was part of the lecture when I was working at Health Economics Research Unit in Aberdeen. So let's start. So I just try to put first the word crowd. I just copied from Google on the terms that you might see for health economics or like to some extent behavioral economics. I plan to talk a little bit about behavioral economics, but after trying to gather all the terms, it seems to be too much to just only talk about health economics alone. So probably today we will mainly talk about health economics term. And yes, as Catherine said, welcome any question if you have, and just then probably, Catherine, you need to let me know, because when I share the screen, I don't see the face or the chat. So if there are any question that people type in, and then maybe we should discuss at some point, please let me know. So
Yes, of
before
course.
we, yep, thank you. Before we start, let me try one activity for breakout rooms. And inspired by Tamara, actually, that probably this breakout room might be a good idea. So I adapt this activity from the activity that we use with our student in Aberdeen, and also some public in Aberdeen, in Scotland, in various places. So this is a case study that try to present you 4 people. And let's assume, as economists like to do, let's assume that we have a limited budget that can only treat 1 people. Who would you choose and why? And in the breakout room, I would like you to talk. Who would you choose and why? Maybe you can give the pros and cons and so on. And then when we gather together, I would just ask probably 2 or 3 people to talk about what they discuss in the breakout room. And I will also give you the poll to show me which one did you choose. So let's start. The first patient is his name is Steve. He's 18 years old. He's a victim of car accident. So he has severe problem on his face, and it's affect his psychology and mental health quite a lot. And it's really, really bad because the scar and everything, it's prevent him from joining or continuing his education. So plastic surgery would help to correct this, and it should be helpful for his mental health as well. So this is the first patient, patient S. Patient J, Joanne, she's 42 years old, has no dependent. She's no longer takes drug at the moment. She has been diagnosed as HIV positive and infected with hepatitis C as a result of her drug takings long time ago. Treatment is available, and the success is 3 out of 4 to extend her life expectancy and minimize symptoms. Patient number 3, patient M, Marianne. She's 65 years old. She need a she need a hip replacement. She already waited for 16 months for her surgery, and soon she will no longer be able to live alone because of her hip. So her son is very far away. He lives 200 miles away. So her hip replacement would allow her to still live independently. Patient D, Daniel, he's 8 years old. He was born with problem with his spine and a quite condition that affect his spinal cord. So this condition cause bladder and bowel control difficulty and paralysis of his leg. So there are some new experimental surgery with the probability of 1 in 5 to improve his mobility. So he would no longer require the use of wheelchair if it's success. So out of these 4 patients, which one would you think that you would like to fund them and why? So this is our 4 patient that we mentioned. And obviously, you know that there's no right or wrong answer in this case. I just want to stir the conversation and hopefully you see that there are quite a different concept that jump out of what we discussed. Like, for example, and this is the key things for economics. Economics try to deal with allocation of scarce resource. So because we have limited resource, that's why we have to think about economics. If you have everything that you can do anything, then you don't have to think about allocation or do it efficiently or the best way, let's say. And there are something about uncertainty, like the probability of success for Daniel, for his novel treatment. But at the same time, this uncertainty also justify risk pooling and insurance, like social health insurance or pub or the provider by the government of this kind of health service. Because not everyone would get, of course, we would get sick and die at some point in our life, everyone, but not everyone got the same kind of sickness. Not everyone going to be costly to the society. So there are room for pooling all these risks. And that's the things that maybe you can say it's the part of uncertainty that we can think about. So it's partly uncertainty about the outcome, and also it's also the uncertainty about what and when will happen, and that might be the chance to pull things and do things better. And that's just one thing that I want to mention. Another one that is very important is about information, perfect information. Do we really have perfect information? In this case, I provide you with some information, but in general, we don't really know. Like, for example, the case of Joanne, who has HIV, maybe maybe she's got it from her drug addiction, or maybe she just got it from something else. We never really know. We might be able to judge or get some information, but do we really know it perfectly? Maybe not. And again, in the general view of economics, it's about choice. So we have the choice to make. And when you're making choice, then there exists the term that economists really like to use. It's called opportunity cost. So this is the not the cost that really incur to anyone, but it's the way to think about the value of things that we sacrifice to make a particular choice. So for example, in this um, exercise that we try to discuss together, if you decide to fund, let's say, patient S, then you wouldn't be able to fund any other patient. And let's say if patient D is the second best choice, then the opportunity cost of funding patient S would be the chance or the foregone benefit of patient D. So that is the way that we try to think when we think about using some resource at one place, then it's not available to use at other place. And that's the cost that economists like to call it opportunity cost. And sorry. And we also have some funding option. And to some extent, today I will talk about economic evaluation. And economics in general, we would like to think about 3 main questions. What, how, and for who. So let me start with the concept that is quite main thing in economics, which is efficiency. I will talk about 3 different type of efficiency: technological efficiency, productive efficiency, and allocative efficiency. sorry. This might be just the graph that you already see. Like I will try not to have so many graphs here. But when we talk about efficiency, like to do something efficient in economics, there are three different definitions. So technical efficiency is like you have all the input, labor, capital to do many things. Like in this graph, the society decide to produce either guns or butter. And on this curve is the curve that they use all the available resource in the country to produce how many guns and how many bottles. So on this curve is the one that we use according to our base technology to produce everything from what we have and achieve that level. There would be something inside this curve that is not efficient because you don't use all the resource, or maybe you use the technology that doesn't give you enough outputs. So technology efficiency is just about maximizing output given the input that you have. But when it comes to productive efficiency, it's about, of course, maximizing the output, but at the same time, at the minimum cost. So it should, when you reach this point, you need to think about the one that costs the less, because maybe in order to produce guns, you might need a lot of capital. Produce butter might need less number of capitals, and then you need more labor kind of stuff. Then it might be true that in some country doing this is cheaper because wage is cheaper, but the cost of capital is so expensive. Then in that case, probably the productive efficiency might be point C, where you produce more butter but less gun, for example. So in that case, it depends on the price, the wage in the country to achieve this. I'm sorry, I somehow mute myself. So anyway, let me recap. It's just like producing maximum output with minimum input. This is technical efficiency. Producing maximum output with minimum cost. This is productive efficiency. But when it comes to allocative efficiency, you have to think about the favorite curve of economics, demand and supply. So it's the point where demand meets supply and you have equilibrium. This one is just for a firm. When you sum all these small Q for a firm, you did get the big Q for the society. And this is about optimum distribution of goods and service. So it's not just about producing it to the very best technology that you have, but also about how to distribute it in order to maximize the social benefit and at the given social cost. So in this case, normally I will not talk in detail, but by economics, we would say that the point where the demand meet the supply is the point that you kind of like maximize the social cost. Let's say if this is the society demand and society supply. So it would be the point where you maximize social benefit given the cost. So having that kind of thing in mind, and I think this is a nice thing to talk about, because as we work in the field of health, many times we tend to think about some kind of government intervention. We know that healthcare provision cannot be left by the market alone. It wouldn't have a good outcome. There would be so many problems. But from the economics point of view, there are mainly 4 reasons why provider of health would not be good to just let the private do. And you might have some justification for some government intervention. So the degree of government intervention is debatable, but there need to be some government intervention. The first one is monopoly. So for example, if you think about some novel treatment that some company can come up with, and they have their own or monopoly power. If the patient has to buy that medicine or treatment from that company, they might not have enough power to bargain. And then in this case, maybe some regulation from the government or something might help to reduce the price, give more access to the society, and so on. Another one is externality, and we even mentioned that in our discussion when we talk about HIV, that patient who has HIV, they can spread the disease to other people. And that is the negative externality of HIV. So if you treat HIV for one person, it's also reduced the chance of spreading. And that's is what we call negative externality that can spread or spill over to other people. So that's the example of negative externality. Positive externality, classic example would be vaccine. In the case that the vaccine has a good rate of immunization and also prevent you from getting the disease and spreading the disease. Then the more people getting vaccine, then it has the positive externality to the society, to the people who doesn't really have the vaccine, for example. Another one is public goods. The public good is something that, let's say, you can think of something like street light that the government provide, local government provide to the citizen. No one can prevent you from benefiting from street light. And also when more people come walk around in that street, it doesn't make the light dimmer or whatever. So in that kind of situation, and to some extent, some health product has some of these public good aspects. When you have public goods and then you don't have the government or anyone to provide that. So let's say if a private person just set up a street light, that person has to pay for it alone without anyone sharing, because no one would say like, I benefit from that, because you have no way to exclude that person out. So that caused something called free rider problem. And in that sense, then when it comes to all these public goods, government intervention is something that kind of justify to have government collects tax from people and then fund it into these public health service, schooling, and so on and so on. So there are like concerns and debatable point about which one is public goods, which one is not. But to some level, education, health has some level of public goods in there. So it's kind of justified the government intervention in it. Another one that is very interesting is asymmetric information, when one side has more information than others. And the classic example that people tend to use from healthcare is the one that describes two situations. Adverse selection is the part that the uninformed side of the market get the wrong people trading with them. So for example, think about private health insurance. When private health insurance come up, it should attract the people who are more likely to sick or have some higher risk. So in that case, then they would attract the people who might know that they are risky in their health behavior or they are more likely to get sick to pay to get into health insurance. So the insurance company suffer from adverse selection. But at the same time, once you get insured and you get protected, then you have somehow moral hazard to do something bad. For example, if a person get insured by a company for his driving, then maybe it's not all the time and not all people act the same. But some people might drive a little more careless because that person know that at least I have the company, the insurer to cover my back. If I got an accident, then they would pay for me. So it's affect the behavior. So with this kind of information that are not symmetry between two sides, it make the trading or the interaction in the market act differently and suffer from this kind of problem. So that might be the terms that you have heard about, adverse selection and moral hazard. And I think it's quite relevant for healthcare in many cases. So that's all about market failure and government intervention. Are there any questions at this point? Because I think I threw a lot of terms in there.
Yes, there is a question. William, would you like to go ahead? Yeah, so I was just wondering, why is a positive externality considered a market failure?
It's considered a market failure because if you think about the private person alone, your private benefit, let me go back to the supply demand curve. So your private benefit, which normally described by the demand curve, would be too low. So if you consider the social benefit as well, the curve would shift higher to something like this, if you see my cursor. So it would be higher demand curve, and then the provision of the service would be higher, and the benefit of the society would be better. But normally people think about their own private benefit rather than the social one. So that's why without some intervention or some help of the government, we wouldn't realize the social benefit of that. Yes. Any other questions on this? Yes. So let me keep this topic about market failure and government intervention behind. And let me just talk about equity. We already mentioned something on efficiency, right? So efficiency is the things that economists in general would like to achieve. Like we like to use the input, the resource to the best. But at the same time, there is something about equity, how the resource is distributed across the society. And there are two main terms that I think it might be useful to think about when you come to equity. The first one is horizontal equity. So in the case of healthcare, you can summarize it as equal treatment for all the equals. So you should provide equal access to to the to everyone who have equal needs in general. So no people with the same health needs or health status should be treated differently. So I think you can think about many examples that horizontal equity is not there in our society, and that might be because of income. Some people with some condition have less income to access that, or less knowledge on how to talk to the doctors to get the best treatment that they should get. So this is about horizontal equity. Another one is vertical equity. And this time is about unequal treatment for the unequals. So, for example, there might be some group of people who have different level of income, different level of education, different aspect of many things in the society. So in that sense, we would like to help the people who are more in needs, like people with low education, with low income, more vulnerable, and so on. So in this case, it's fair or still equity, a good equity, to just provide extra resource for those group of people. And I think there are so many different definition of equity. And this one that I chose is from Mooney, which is like a text in health economics. And he described 7 definition of equity. Depend on which definition that you use, you can consider different type of equity. I would say the first 3, equal expenditure, equal inputs, or equal inputs. For needs, maybe this is not the one that we strive for. In general, the society try to get equal access or equal utilization. And like the the final goal, we would like to achieve equal health. So let me give you some example of something that might be different. So for example, the country that has universal health coverage, you might be able to say that in theory, it's provide equal access for everyone who has equal needs. But normally we don't see equal um, access, maybe because of the distance to the health facility or other thing else. And even with equal access, sometimes we don't see equal utilization, because some people might utilize it more or utilize it less. It might be about how you view the problem about your health, or how you view the service, like some kind of prevention and health promotion might not be utilized by everyone. And after all this, even though people utilize all the service and everything that we provide, there might be their behavior in their private life that make the equal health not achievable. So these are different layers of equity that we can think about. And yeah, it's very difficult to achieve it, but I think it's a good um, gold standard to think when you try to form some policy, form some intervention, what kind or what level of equity that you realistically be able to achieve, or what might be the one that you would strive for if it's possible. So that's something about equity, and I hope it's answered some earlier question about how we think on this, how to justify the way we allocate resource and so on. So the question about efficiency and equity is the key for economics framework. So if there's no question, I would like to continue a little more. So in theory, we can think of something like a society that try to pool the risk and pool the resource and try to get it to the people who needs it. So for example, the top diagram here, it's the difference between people who have low risk and high risk. So people who have low risk should have lower utilization, right? But let's say if they are contributing the same amount, the resource should be transferred to the one who have high risk in order to get high utilization. But in case of subsidy, when you have two different group of people with high or low income, and let's say they need the same level of healthcare. So in order to ensure horizontal equity, then we have to redistribute the resource in order to ensure equal utilization. So the rest of my talk today would be mainly about economic evaluation. And it tend to be the things that talk a lot in health economics. And many people think that economic evaluation is equal to health economics, which is not true. But it's the tools that help us to think about priority setting and resource allocation. The general things that we have to think about, and I don't have time to cover all this, but the general things that we have to think about in economic evaluation is about cost, how to identify it, how to measure it, and how to value. Benefit, how to measure benefit, and about something on uncertainty. I will talk a lot about cost, and the benefit is totally different part that beyond this talk, and uncertainty is not either. But if we have any question that you want to talk a little bit more about this later, let me know. So let's say there's intervention A and intervention B. So this is the classic example of economic evaluation. When you want to compare current practice with new practice. So you have to think about the total cost of it, the total effects or the total benefit of it. And then you get the cost over effects. And then that's the things that you can think about. But in general, when economists think about this sort of thing, when I say about NICE, which is the organization in the UK that think about what kind of new medication or new treatment that they want to fund, they more likely talk about this incremental cost effects ratio. And that's come from the difference between the cost of the new intervention minus the old one, and that's the numerator, and the effects of the new medication compared to the old one, and that's the denominator. So this ratio, like I said, Like, for example, 25,000 pounds per one quarry. This is the things that it it is used for making decision. And it depends on how you set the decision rule. In the UK, as I said, NICE tend to come up with something around 20 to 30,000 pound per quarry. And that's the business, the very huge business that people who submit new medicine or try to convince NHS to do some kind of new treatment has to play around with their assumption, their model in order to achieve these kind of numbers. But that's another thing. So when we talk about economic evaluation, there are four main types that I think I would like to mention and probably give you some better ideas on this. And I will probably not go too far into the detail. So the first one is cost minimization. This technique is just try to think about what is the monetary value of the cost, and you choose the method that minimizes the cost. And we don't care much about the outcome. Another one that probably people tend to use this term when they talk about economic evaluation is cost effectiveness. But within economics, when you talk about cost effectiveness, it's just this second method or second type of economic evaluation, where you consider monetary value and some natural unit, like how many lives saved, how many treatment done, or how many days of hospital stay that we can reduce, and so on and so on. So you compare with certain type of outcome, but it tend to be unique dimensional measure. So just one type of outcome. It's can with this kind of thing, the same to cost minimization. We just think about more like the technical or productive efficiency. So we try to maximize output with the cheapest cost. That's the things that we think about when you think of these two types of economic evaluation. The third one is cost utility analysis. This one is the one that tend to be used a lot in the UK. And it's the comparison of monetary cost again with utility value. And in the UK and many, many countries, they use something called QALY, which is quality adjusted life years. And with per unit of QALY, how much do you pay? And this gives extra ability to compare. So you can compare between two treatment of two different disease. And in that case, it's not just about the productive efficiency anymore. It's not just about maximizing output or maximizing health given the cost, but it's about maximizing health given the cost and compare between all different treatments and all different disease group and so on. So this has some allocative efficiency within the health sector. So maybe you can decide that there are some intervention in the maternal unit that seems to be more cost effective, and the cost per quality is cheaper than doing something in, I don't know, emergency medicine or something like that. The last one is cost benefit analysis. And this is the comparison between monetary value and monetary value. Of course, this requires a lot more assumption because there are so many benefits that you can't assign monetary value easily. But the nice thing about using cost benefit analysis is that you can compare these cost and benefit, and let's say cost per benefit of doing something across all sectors. It's not just within health. You can compare the intervention in the maternal unit with building new school, with building new roads, and so on and so on. So that's a more broader one. But of course, it's require a lot more information, a lot more work, and assumption to some level. So as I said before, the type of economic evaluation just the main difference comes from how to measure benefit. So, as I said, we think about something called productive efficiency, is how to provide healthcare, and allocative efficiency, what healthcare to provide, like, or how to distribute it. So these are the two different questions that we try to answer when we think about economic evaluation. For example, productive efficiency would be that, as I said, given the level of output, how can we produce it at the minimum cost? Or how can we maximize the output given the cost? It tends to concern only efficiency within that program, within that intervention. Like, given this kind of goal or outcome, how can we best achieving it with cheapest method and so on. So, for example, if you want to providing rheumatology clinic, is it best to provide it with a nurse practitioner or a consultant-based service? That kind of thing. This is pretty much about how to achieve the same level of health outcome with cheaper cost. When it comes to allocative efficiency, this is the things that we have to think about competing resource between different programs. Like, are you going to finance the gynecology service, renal service, intensive care, or anything? So the question would be more like, should there be some kind of expansion for rheumatology clinic or renal service, for example? So it's more about comparing across program, across intervention, rather than just particular one intervention, one program, and so on. But to some extent, maybe you can also think about allocation across different geographic area. That can also be the case, because when you think about intervention, it might have some intervention in the north and in the south and so on, and there might be a better way to deploy resource by allocate the resource differently, and then people both in the north and the south get better treatment for that. So at this point, are there any question or any comments on this? Then let me continue a little bit. So as I said before, the cost minimization is just about try to compute the cost and minimize it. And it's just, the problem would be just the uncertainty surrounding the estimate, not much about the benefit, because there's no benefit there. For cost effectiveness, this is the cost per unit effects. So for example, as I mentioned, like the cost per life saved, the cost per Down syndrome fetus detect, the cost per disability days award, for example. But it's nice to have this kind of unit, but at the end, how can you compare one life saved with how many days of disability days award? This is quite difficult. And that's why in the literature, they try to come up with something else, like cost utility analysis. So it can address both this productive and allocative efficiency. So the example that we tend to use, or it's used a lot in the healthcare sector, is quality adjusted life year. There are something that available in the literature, but less popular, like disability adjusted life year and so on. So it's combined between life year gain with some judgment of the quality of those life years. So the example of how to measure the gain in quality adjusted life year. So let's say we have perfect health that equal to 1, worst imaginable health, which is equal to 0, and then the life year that this person can live longer. So let's say without the surgery, that person would have only 0.2 quality of health, and can live only 3 years. But with the surgery, this person can live longer to 10 years and also with better quality of life, 2.9. Then in this case, the quality gain from this surgery would be 8.4. And to link it with the things that we discussed before, let me go back and show you this. So this is the effect here. So this is 8.4 would plug in to this denominator here. And the cost would be the cost between surgery and no surgery, for example. So that's the way that we compute this kind of numbers in economic evaluation. The last one is cost-benefit analysis. And this is the broadest form. It can address productive and allocative efficiency, and the effects try to measure it in monetary terms. But there are so many things that can't be measured easily by monetary terms, like human capital, like people who study and gain more skill. How can you measure those kind of skill, the value of skill, or the things that we call human capital? But sometimes things can be done by asking for willingness to pay. How much the society want to pay if, or a person, maybe not a society, when you ask the person, how much do you willing to pay if we apply this intervention that would help to reduce air pollution in your area? So how much you would like to pay? And with that numbers, we gather all this information and try to calculate this number. And we can use this as some kind of proxy for the benefit, because the things that people want to pay, that's signal that, at least in economics assumption, it's signal that when you want to pay for this amount, you value something at that level. Otherwise, you would pay more or you would pay less. So in that sense, this willingness to pay can be calculated and get it as a benefit. So that's one strategy that can be done, but there are so many more. So for example, the things that we can think about when we think about cost benefit analysis is like an intervention in maternal and newborn health service delivery versus like investment in a new school building. Which one is better? So there are many, many ways to think about it. There are some many numbers and indicators that people use in finance, but recently in public health, people tend to think about this in terms of return on investment. How many percent of return on investment that you have from this project? And you can compare, let's say, the vaccination program have this X% of return to investment, and then you can compare with building new school, which has this Y% of return on investment. And that at the more general level, it can be compared across sector, health with education, with transport, with defense, and with many, many other things else. So let me just try to be a little bit more precise on the cost, and I will finish my discussion today and welcome any question or any comments. So the resources have opportunity cost. So we want to identify, measure, and value the resource use. So with this kind of opportunity cost in the mind, then we try to think on how to do the costing in economic evaluation. How can we identify the cost? And this is just an example to give you some ideas. Maybe some of you already did this kind of costing in your field, and it might be even more detailed than this, but I just want to give some ideas on what can be done. So the first thing that we have to think about is the direct cost, the healthcare resource that we use, like staffing, overhead, capital, consumable, and so on, other related service. So when we have the healthcare service, it can't stay alone. It needs some ambulance service, maybe community service, or some volunteering things that support the system. And there are also the costs that doesn't cost to the system, but it costs to the patient or their family, like out-of-pocket payment, travel to the health facility, and so on. When we want to think about the social cost, the social direct cost, we have to think broadly about these kind of things. Cost would be something that is not indirectly come from the things that we do. But for example, if people go to hospital to have some treatment, then there are some time lost for their work. This is the things that it's an indirect cost to themselves. Or let's say these kind of indirect costs would lead to some kind of loss in production, like some people have to get out of their labor force and have to do some housework, or cannot do any housework or any chores, any activities, and so on. This kind of indirect costs could be one of the things that we should consider when we think about the cost. But if you flip it on the other side, let's say if the treatment help people to reduce the time lost from work and so on, it can be indirect benefit as well. So it depends on how you flip the side and look at these kind of things. So the main things about economic evaluation, both cost and benefit, is about the viewpoint. So do you think about it as society? Do you think about it as the healthcare sector like NHS? Do you think about it as the patient, the employer, the family, and so on? So the view of the cost would affect how you contribute computing the cost. And there are also the common costs that you can pool across programs, like the hospital building can be pooled across different wards and so on. And the time frame, and this is quite important. How can we treat the things that has benefit far in the future, or the one which has the benefit a little bit immediate now? And that's depend on how you discount the future, how you calculate and discount that. So the measurement of the cost, I just try to give some example here. When you come to staff, then it's about their time. When it's come to overhead, it's about the amount consumed or unit consumed. Maybe you need medical records and patient survey to calculate these kind of things. Sorry. So when we have all this information about number of people that we use and the wage rate or the unit cost that it costs, then we can sum together and get all these costs. There are many, many types of costs, like total cost, that is the total cost of everything, the average cost, which is the cost per patient, and so on. Marginal cost is the thing that economists really love because it's about extra cost of producing one extra unit of output. And fixed and variable costs, which is also very important because fixed costs tend to be the things that attach to the things that you can't adjust or in the short run. Like the hospital has X number of rooms, the hospital have Y number of equipment. You can't change that in the short run. And the cost that come from there has to be fixed, even though you have so little number of patients using that equipment, then the fixed cost is already there. But the variable costs are the things that has to be done per unit, like food, medical supplies, and so on. Other type of costs that I just try to throw in here, and then that's the end of my talk because I think it's already too much. It's about something like monetary versus non-monetary benefits or costs. We have to think like how far are we going to include these non-monetary things into our calculation. And sometimes it's about tangible, intangible. Like there are some intangible costs or intangible benefit. How far are we going to include those kind of things? And as I said before, it's about the wheel between private and social. The social cost, the private cost, which one are you going to consider? As a hospital, maybe you have different way of considering about the cost and benefit. As a government who cares about the whole society, that's totally different things. So that's probably the things that we have to take into account. And I just have this as the example of how to measure benefits. So when you have the disease that reduce the quality of life, if there are intervention, then the prognosis with intervention compared with the one without intervention, this is the health gain. And that's just to sum up some broad idea of measuring benefit.